Okay, well, good morning, everybody. Welcome. Delighted to see so many people here in this hall, and welcome if you're joining us on this live streaming to you wherever you are as well. This is our fifth report, and we're really pleased to be able to share it with you today, share some of the headline findings. And the plan for this morning is I'm going to speak and just present some of the key highlights from the report, the work that my colleagues have done, and that will then leave us for about half an hour for questions, which can come from the hall, and my colleagues will join in answering those questions. But also, I think for those of you not in the room, we'll use Twitter as a way of sourcing some of the questions and getting some participation from outside of the room in the conversation we're having today. So this is our fifth report. It's an important report for us because the work that Mike's been doing in relation to hospital inspections is now prominent in here, and the work that Andrea and Steve have been doing to change the adult social care and primary medical services questions, the green shoots of that are beginning to show in this report. So it is a reflection of some of our new and changed methodologies. But what's our key message? And our key message, simple headline, is that we've found many examples of good and outstanding care. But we've also found wide variations in the quality of care that we've found. And we think it's this wide variation in the quality and safety of care which is unacceptable. And why is it unacceptable? Because what this means is that there are some people, patients using hospitals, people using adult social care services, people using primary medical services, who are not getting access to a high quality of care. And we think that people who are using services want the confidence and the trust that the care that they're receiving is safe and high quality. So that's why this is important. So let's go into some of the issues that we've found. What are some of the key headlines for this? Now, amongst the variation that we've identified, and we'll say a bit more about this as we go through the presentation, and there's a lot more detail in the report. This presentation, by definition, is going to be pretty high level and is not going to touch on every one of the findings that we've made. But this is one of our key findings. The principle of keeping people safe is fundamental to the work we do right across our range of responsibilities. And that's why variation is a key issue for us. And what we've found in the report is that there's been a lack of effective safety processes. And we think this arises, it stems from the absence of a culture that is open, that carries out investigation when mistakes are made, and then learns from that, and then changes what is going to be done in that particular service, that particular institution, as a consequence of that learning. And that goes further, we think, that the responsibility for developing that culture sits with the leadership of an organisation. Strong, effective leadership at all levels in an organisation, organisational leadership, service leadership and practice leadership, is absolutely crucial for developing a culture of safety, a culture of openness, a culture of learning, which is absolutely essential for the delivery and development of safe and effective services. Good leadership drives up quality and delivers safety. It engages and supports staff in the creation of that culture. What do people in organisations do? They watch what the leaders do. And if the leaders value safety, then safety will be a priority. And where we looked at the very best services, we found good leadership developing a culture of safety. Say a bit more about this as we go through. I'll begin now with adult social care, the work that Andrea and her teams have been leading. And what we see in adult social care are staff recruitment and the training and development of staff being a key issue. It's a major issue for the future. Supporting staff to be the best they can be, to actually deliver sensitive care to people with complex needs, is critical. But on this theme of leadership, the evidence in the report is pretty clear that for those services which have a registered manager in place, using our traditional methodology, where there is a registered manager, they will meet over 90% of the standards that we're measuring them against. Where there's an absence of a registered manager, they'll meet about 70% of the standards. The conclusion from this is pretty clear. Good management, good leadership makes a difference. There's more of a chance that standards are going to be delivered, and what that means is better and good care is going to be delivered to people. That's why registered managers are important, and us taking a tough stance where registered managers aren't there for long periods of time is absolutely critical. And what was our biggest concern in relation to our inspections of adult social care? Well, it was this theme of safety and safeguarding, not just how people are cared for, but whether people's well-being is being promoted and people are being kept safe. Come now to the work that Mike and his teams have been leading. We've done a significant number of inspections now using the new methodology, and it's important to stress that the rollout of this new inspection methodology began with those hospitals, those trusts where we felt there was greatest risk. So this is a skewed sample, but nevertheless what we found is that staff in hospitals are caring. This was the top performing area in terms of the 5 key questions that we ask. Staff were caring. We also saw, again, good leadership lies at the heart of safe, effective and responsive care services. But we did have concerns about how safe services were and whether trusts and hospitals could demonstrate that services were as safe as they needed to be. And we identified safety as being a key issue. We also think there's good evidence of where services are effective, but there is undoubtedly more work to do in relation to the measurement of effectiveness. Similarly for responsiveness. We can cut this a different way. When Mike and the teams go out to look at how these 5 questions of safety, effectiveness, caring, responsiveness and leadership are being answered in services, we also ask these questions about against the 8 core services. These are on this slide: accident and emergency, medical services, surgery, intensive and critical care, maternity and family planning, services for children, end of life and outpatient services. And what we found is accident and emergency and medical care were of most concern. Often accident and emergency can be overcrowded with long waits, often caused by the flow through hospitals. It may not be an issue about accident and emergency, but the flow through in hospitals. Medical wards can sometimes be good, except there may be 1 or 2 what we've termed in the report worry wards. These can often be wards for the care of older people or escalation wards where hospitals are under some pressure. Good care was found in critical care and services for children and young people. Outpatients was frequently poorly organised and poorly managed. So this is, again, variation, not just between hospitals and trusts, but also within hospitals, variations. Indeed, we've inspected one hospital which carried a rating of inadequate for the answer of one question in one service, but was also rated as outstanding in responsiveness in the end-of-life care. So variations within services as well as across services. So how might we distill some of these messages? We do think it's important that we continue to champion and find good care, and where we find that good care, it's just as important as that we call that excellent care as it is that we identify care which is inadequate and requires improvement. And we found this in Frimley Park. Frimley Park was the first hospital that Mike and the team have rated as outstanding, and it's essential that we do rate hospitals as outstanding and good, because that allows others to actually look at what it is about that hospital that is good and outstanding, so they can learn from the best and take some of those practices so they can improve in the way that they deliver services. But critically on this point of leadership, we found that some 60% of hospitals had more to do in relation to the development of their leadership. Not leadership just at the top of the organisations, but leadership throughout the organisation, a distributed leadership, which is just as important in leading services and leading wards. And within our overall findings, it's A&E and medical services that requires the most improvement. We have, importantly for our work, created a specific inspection service for mental health services. It's led by Dr. Paul Lelliot, who I think is providing really excellent leadership to the development of this work. And in mental health services, again, we found this variation, good and committed staff, some really impressive examples of multidisciplinary working across professionals, and good systems in place to safeguard the welfare and well-being of people who are using services. But we also found services which required improvement. The physical fabric, the environment, the physical environment of many mental health services requires improvement. There are services where there are not beds available for people in an emergency, and I think this would contrast with the beds that are available for people who have physical healthcare needs. And people who are having a crisis in the community, who require being taken to a place of safety, who are not always being taken to a healthcare place of safety. Too many people remaining in police custody who absolutely need access to appropriate healthcare services and treatment. So again, the theme of variation working its way into our findings on mental health services. And primary medical services, the work that Steve and his team have been doing, developing our new methodologies. We rolled these out from the 1st of October, but where we found good practice, we found a correlation between GP practices with larger patient lists delivered better care, better quality of care than those with smaller patient lists. We also found, and there's almost something counterintuitive about this, that most GP out-of-hours services were safe, effective, caring, responsive and well-led. Very interesting, a piece of good news that got fewer column inches in the reports than some of the bad news stories which have come out from our inspections, but nevertheless a significant improvement over the period of time given the criticisms that surrounded out-of-hours care historically. And we do regulate dentists, primary dental services, and over 95% of dental practices met quality standards, showing an improvement over the 92% that met these standards in 2011-2012 when these inspections were first carried out. So if there's some of the key themes that we've identified in the report, some of the themes that we've found through our inspections and we want to highlight, there's many more examples of good and outstanding practice in the report to demonstrate what good and effective care looks like. We've identified where there is poor care, and we've quoted examples in the report in the interest of absolute transparency. So this leads us to the question about, well, what can we do about this? What are we asking providers to do, members of the public to do? What are we asking of ourselves, and what is it that we're going to do? So these next few slides are attempting to answer some of those challenges, some of those questions, and it may well be that these are some of the issues you want to discuss with us as we go through the question and answer session which is going to follow. So firstly, what is it that we think that members of the public can do? Well, in our report, we emphasise the importance of transparency. We've used the phrase intelligent transparency in the report. David has written separately about intelligent transparency. And it seems to us that what our job is to regulate and inspect health and care services and then publish what we find and where we find good care, publish that we've found good care, and where we've found care which is inadequate and requires improvement, publish that. And why do we do this? Well, I think we do this for two reasons. Firstly, we do this so members of the public can receive information that they have some trust and confidence in, that they can then use to make informed choices about how they will use services. I think that's particularly the case in relation to adult social care, where the evidence is that people do use information to select care homes, domiciliary care services, particularly those people who are self-funders. I think many people using acute healthcare services will actually use information to make decisions about the choice of services where they've got a choice. I'm thinking here of maternity services and women choosing where they may and how they may give birth. But there are other services where people have less of a choice. It may well be people without capacity, people with dementia, people without the mental capacity to make the decisions. And this information is essential for their carers, their advocates, to actually assist them in making those choices. But we also think there's a reason for professionals to actually consider our judgments, because our belief is that it allows professionals in one service to benchmark themselves with another service and to use that benchmark information to actually improve their services. The example that we've used in our report is we thought the accident and emergency services at the Homerton were delivering good care. For those accident and emergency services where we've said the care is less good, it's open now for those services to look at what they're doing at the Homerton and to use that as a platform to learn and improve what they're doing. And by making it transparent, it not only helps people to make choices about services, but it also allows professionals to benchmark their services against other services and use that information to improve. So we want our information to help people make judgments, and that's the reason we make it transparent, but we also want professionals to use our judgments to help them benchmark themselves so that they can use it as a platform for improvement. We want you to give us feedback on good and bad care. We can do this not just in our inspections, but through our website, and we use that intelligence to inform when we inspect, what we inspect, and how we inspect it. So it's important that the members of the public have confidence in our judgments and feel able to use them. And by publishing them, making them transparent, we hope that we're making a contribution to members of the public making informed choices. So what should providers do? This is a real challenge, I think, to how open our services are right across adult social care, primary medical services and healthcare to feedback, and whether that feedback really is being used to inform improvements in services. One of our worries is whether providers accept our findings and use them as a platform to drive improvements in the quality of their services. Are our reports being used as a challenge to the integrity of the organisation? It can be hard if you lead an organisation and we come in and say, actually, the leadership here is not developing a culture of quality and safety. That's a hard message to take. And people can accept that message and say, we accept this and there's more we can do. We will use this report as a platform for improvement. We will learn from the best in the interest of our patients, in the interest of people that use services. Or is this something that people are going to use and deny that there is a problem, say we don't understand, and not use it as a platform for improvement? So there are some key challenges here, and we're calling in this report for providers to use our reports as a platform for improvement, to use this as feedback which allows you to benchmark your services with others ask key questions about what you need to do to improve, so that the communities that you serve, the people that you serve, can have the confidence that they're receiving services of the best and highest quality. We also think that by identifying where improvements need to take place, organisations can take responsibility for improvement in their own right. But we also acknowledge that some organisations will need help. They'll need help from the wider system. So in terms of healthcare trust, it may well be that those services need help to improve from Monitor, from the Trust Development Authority. But they might also need help from the commissioners, the Clinical Commissioning Group, or NHS England in relation to it. And accepting there's an issue, accepting there is a problem that needs to be solved, is the first stage in being able to ask for help so that services can improve in the interests of people that are there to serve. And I think there is some good evidence from the work that Mike has done in relation, and we quote the example of Basildon and Thurrock in our report, of where they were in special measures, but they've worked hard, they've accepted the feedback, they've accepted help from others, and the consequence of this is that they've demonstrated they were able to improve and were rated as good as a result of the most recent inspection. So a clear example of an organisation listening to the feedback, taking the messages from our report, taking help from others, and the consequence of that is improvements have taken place, and the people served by that hospital are getting better services as a consequence. So we invite providers to use our reports as a platform for improvement. And what does this mean for us? What role have we got to play? Because we have an important role, and we're on a journey of improvement ourselves, a journey to excellence ourselves. So there are things that we can continue to do in terms of reducing variation in health and care. And I think we will continue to develop our new tougher and expert-led inspections. Mike and Andrea and Steve are rolling out from the 1st of October our new inspection methodologies in primary medical services and adult social care, and we'll continue to develop our approach to this. We'll continue to publish our reports, make them available so we can actually continue to contribute to the transparency which we believe is a platform for the improvements that need to take place, so that people can benchmark their services against others, so people who use services can make informed choices. Critically, we want to encourage a learning culture. A lot of debate about blame and learning that has taken place over the past couple of years. And we believe that services improve where people can learn. And we think our reports are an essential part of the feedback about the quality of care, where people can then use those reports to create a learning culture. The whole purpose of identifying good and outstanding care is so people who use services can have confidence in those services. But also, it encourages people who are not delivering good and outstanding care to learn from the best. What this report shows is that there is good care. It is possible to deliver that care within the financial constraints that exist currently, and people can learn from the best. We want to encourage that learning culture. And we've been thinking a lot within CQC recently about what the Act tells us is an essential part of our role. And what it says is we exist to regulate and inspect health and care services, but we do that for the purpose of encouraging improvement. Our job is to encourage improvement. Our inspection reports are prepared on that basis. And this report is offered to you today as a way of encouraging improvement right across the system. That's why we identify what good and outstanding care looks like, as well as saying this care is inadequate and requires improvement. It's part of the role that we have to encourage improvement. We are not an improvement agency. It is not our job to do that improvement, but we are an agent of improvement. And by identifying through this report today where good care exists, where inadequate care exists, we are making a contribution to encouraging the improvement. So thanks very much for coming to join us today. Thanks very much for everything you've done to help us in producing this report, challenging us in terms of our new methodologies, contributing to that. It's been an essential part of our journey. So I think what we now do is, I think David is now going to take over and chair a question and answer session. I think we're going to take questions from the floor first, and then I think the team that have been setting this up have got a means to actually get questions in from outside of the room, and we'll have a go at answering those as well. So thanks very much for listening, and David, over to you.
Question from the floor. The lady here. The microphone coming around. Maybe you could just tell us your name and your particular interest as well. Thank you.
I'm the Director of Services for Leonard Cheshire Disability. Really welcome the report and the boost in terms of improving more of learning cultures. And we have definitely found the reports from CQC to be a vital part of that when we're working with our services and learning from each other. Pleased to see the issue in the report of the 15-minute calls in domiciliary care raised as an area of focus. And David, you mentioned about providers sometimes needing wider support from the wider system in terms of us working together. Accepting that providers have a real responsibility in deploying staff effectively, but it's very difficult on occasions when often commissioners are still very much focused on time and task solely, as opposed to the outcomes for people. And I'd be interested in the panel's view on how we could all be working together to better achieve this.
Thank you for that. David, do you want to kick off with that, and then to Andrea?
Yeah, so as you know, we don't have a formal role in inspecting and regulating commissioning, but we do, through our inspection reports, see what the consequences very often of that commissioning are and the impact of that on people who are using services. So we did want to flag this as an issue. I do know, and I think Leonard Cheshire, you've played some part in raising this issue nationally as well. And I do know that, David's in the room, David Pearson, colleagues from ADSS are actually doing some work on how commissioning can develop and improve. And they are going to be carrying out some further work on commissioning. So again, I think it's an example of, within our area of responsibility, we can identify an issue alongside others that have identified an issue. And I think that's leading to a conversation which ultimately I think will lead to improvements in the way that commissioning is taking place. So I think we are an important part of that process, but the solution, the improvement, will get taken forward by others and not just by CQC.
Thank you. I think that Andrea thinks that's covered the question from her point of view as well. So, a gentleman on your left.
I'm Frank Hurst, I'm the Chief Executive of the Registered Nursing Home Association and the Nursing Home Owner. Not naturally, of course, my concern is in relation to the way in which the report, I think, unnecessarily is critical of nursing homes rather than taking the opportunity of promoting them. Much poorer in relation to residential homes is not a positive statement by my identification. But I want to just David's response there, I think just is at the heart of this. We're identified as being not having or not being able to recruit sufficient nurses. We compete with the NHS for nurses, but we can't compete on a like ground. The NHS is far more able to provide a higher salary for nurses. So therefore, we don't provide our nurses. We rely upon Health Education England to train nurses, but their 5.6 billion budget is spent on training nurses, mainly for the NHS. We're mindful of us, but there just aren't enough there. Even the Migration Advisory Committee have now again open up the question of whether we should recruit from abroad to try and satisfy this question. I think David's comment was that you don't have responsibility for monitoring commissioning, but I do think you could draw much greater observations in relation to the lack of commissioning. Maybe you could ask the Institute of Public Care to actually look at the consequences of the different counties against the standards that you find.
Thank you. And Andrea.
Thank you very much, Frank, for the question. And I think that the important thing for us to do is to highlight the issue of nursing in adult social care, because we did see a difference, both in terms of ability to recruit, as you quite rightly say, and then the levels of compliance in our old language against standards between nursing homes and care homes, which I think we've discussed and I've discussed with other providers as well, is directly linked to our difficulties in getting nursing staff into adult social care. So I think that we need to use our report today as part of that groundswell of opinion to say nursing matters for adult social care. We need Health Education England and others to be thinking about social care as well as the NHS when we're doing both the planning of numbers for the workforce, training and support, but also for all of us to be highlighting the really positive roles that people can have as nurses in adult social care and promote that as a career opportunity. But I absolutely understand the kind of challenges that exist, but I want to add our voice to trying to get an improvement in the situation.
Yeah. The microphone.
Simon Gillespie, Chief Executive of the British Heart Foundation. Two brief questions. The first of which is that we've got very much an organisational or service-based assessment here. We are emphasising integrated care in everything we do, so what baseline is CQC going to use on a scale of how effective that integration has been or will be in the future from the patient's point of view, not the organisation's concerned? And the second of which is, do CQC recognise that end-of-life care for heart patients is a Cinderella service, and what can be done about it?
Mike?
The answer, first of all, on integration, all three of us are absolutely seized with the fact that we need to look at integration, and we can do that while still looking at our own individual areas. So, for example, if we are looking at hospital services, we can ask pertinent questions about how well they are linking with GPs, and we can ask the GPs in the locality what they think of the way that the hospital is integrating with them. And so we are working on how to do that best. I think in terms of end-of-life care, absolutely, we have said we are wanting to look at end-of-life care, certainly from a hospital point of view, across the whole hospital. That is not just the people who get to specialist palliative care services. We want to look at the whole entity of end-of-life care. One of the first questions we ask is, how many people die in this hospital in a year? If they don't know the answer to that, they're probably not planning for it, and they're not doing it in a good way. What happens to people who die in the A&E department? What happens across the hospital? And there are some hospitals that are doing this extremely well and have got a handle on the whole of end-of-life care, and you can see it also in their referrals to specialist palliative care that they're no longer 95% cancer patients, but they've got a much broader spread of patients. So that is why we've put end-of-life care as one of our core services that we look at in every hospital we go into, and indeed within every community health service we go into as well.
In the front.
Thank you very much. David Pearson, President of the Association of Directors of Adult Social Services. And first of all, I would like to congratulate you on what I think is a very balanced but also challenging report. And I think there are a number of examples of how you've played in all the issues. And I think the challenges to the system and to providers is completely reasonable. So I think the issue that I was going to focus on, though, is around turnover of staff in social care, which I think is a real concern. We've already touched on the registered nursing issue, and it seems to me that is something that has to be dealt with by a partnership between the NHS, commissioners and providers to do something about that, because clearly it's not a good place to be. But my second point was that you've rightly focused on leadership and made that point very strongly. But I also noted that in the turnover stats around workforce, it's high in other areas too. And I wondered what your reflections were on the sort of balance of impact of the general turnover of staffing levels and what the issues are in that, if you've got any intelligence on that. Thank you.
Andrea.
Okay, thank you very much, David, and thanks for your welcome for the report as well. Because, as you quite rightly say, the challenge is not just for providers, it is for the system, which includes commissioners both in local authorities and in clinical commissioning groups, and indeed at NHS England on specialist commissioning. Picking up your points about turnover of staff, yes, we've highlighted the importance of the workforce actually throughout the report, but focusing in adult social care particularly, because we have seen that where there is a high turnover, that lack of continuity of care for people, particularly if for whatever reason you've got communication difficulties, constantly having to kind of explain things to new people or get used to new environments, really very, very difficult for people living with dementia or with learning disabilities or mental health problems. So we have identified it because we think it's an issue. It's something that we use the information from Skills for Care in terms of as an indicator of concern if we're seeing very high levels of turnover. But it's also something that I think that we have to think about what can we do to address it. And yes, we can highlight the problems and highlight the impact that it has, and it will be a focus of our new inspection approach. But I think that there's then something about all of us throughout the system thinking about how can we make roles in adult social care attractive. Some of that has frankly got to have something to do with how much we pay people and how much is actually put into the contracts to be able to pay people so that folk are attracted to it. We do have to be thinking about retention in terms of training and support and development and making the most of that. Frank made the very good point earlier about the amount of funding that's available for training in the health service and thinking about how we can sustain that better in adult social care is important as well. And we've also got to make sure that we're promoting some of the fantastic roles that there are for people in adult social care and the ability for people, when we do it right, to transform people's lives. And it can be fantastic, and we should be encouraging that.
There's someone who's an expert by experience, the lady there, yes please, yeah.
Hello, Sarah Reid. I'm an expert by experience and a dementia communication activist. The report clearly shows the CQC's commitment to being a new force for change, and many of us share your hope and expectation that the way of measuring services will deliver better results for everyone in the long term and restore confidence in the system. But we all know that many long-term endemic problems are to be found in the wider health and social care system, such as budget cuts, tightened eligibility criteria, and ceilings on care packages, to name but three. How can the CQC affect these outside but related issues, or are its powers constrained by its function as an inspectorate?
David.
Blimey. Well, I think it's a really important question. And so one of the things we've done both in the report, and I've done a little bit of media last night and today in relation to this, and we are placing this argument about variation in the context of the money that's available in the system. And I mean system generally, adult social care, primary medical services and acute health care. And I think one of the challenges is, and it comes to a number of the questions that have come so far, and there are graphs in here in the section on adult social care, it picks up on some of the things that Andrea was saying, is why have we got such wide variation across adult social care when actually the funding constraints are pretty consistent across the country. Most local authorities are struggling, not all, I'm told, by people in local authorities, but the vast majority are. I think we've used the phrase an 8% reduction in spending over this past 2 to 3 years in relation to adult social care. What is clear, though, is some providers have maintained quality standards throughout that period of time, and indeed some have probably improved their standards during that period of time. And that contrasts with some where standards have gone down. This is why we're identifying leadership. It doesn't mean leadership, somebody who's got chief exec on the door, but the shift leader in a home could actually make a huge difference to the quality of care that somebody receives. So we are, I think, not ducking that issue around there is a financial constraint that people are operating within, but actually we are identifying that even within that there's still huge variation that exists, and I think there are challenges there for people providing services and indeed people commissioning services about how that variation, how do we explain that variation? So I don't think we are ducking the issues about that. I'll not go through all the bits of it, but essentially that's it. And it goes back to the point we were making about transparency. And we think it's important that we raise these questions. If we don't raise these questions, we're not, in a sense, reflecting what people who use services are telling us about their experiences of services. And that's important. That doesn't mean we're against those of you that are providing services, Frank's organisation. I think in the summary on the adult social care section, we were trying to say that actually use our intelligence about the recruitment of nurses to actually drive conversations with Health Education England about what contribution could be made to improving this. So it's not, we don't want this report to be about blaming people. We want this report to be about informing conversations and bringing a focus to those conversations that can actually begin to address these issues.
Thank you. Peter Walsh from the patient safety charity Action Against Medical Accidents. First of all, congratulations to the CQC on your report and also to your direction of travel, your emerging direction of travel on monitoring and inspection of health and social care. I think increasingly it chimes with what patients and the public would like to see. But we appreciate its work in progress, and my question is about two fundamental concerns of ours. One is, how do you plan to reconcile your approach of wanting to look for good, as you put it, and move away from monitoring compliance with the legitimate expectation of patients and the public that you will specifically and robustly monitor and regulate compliance with the new fundamental standards introduced as a result of the Mid-Staffordshire public inquiry? And as a symptom of that, if you like, do you plan to introduce any extra weighting to the topic of patient safety? In the example in your report, page 51, for example, of Royal Berkshire, there are 5 out of 8 areas where the trust is needing improvement or inadequate on patient safety, and yet has an overall rating for patient safety of needs improvement. With St George's NHS Trust, I believe they were found to be needing improvement on patient safety, but had an overall rating of good. So if patient safety really is the top priority, shouldn't it be given extra weighting in these ratings and not give false assurances to people? Thank you.
Maybe I could have a crack at answering that one, Mike. We had a long discussion at the board on, I think, 3 occasions about whether or not we should have an extra weighting for safety as compared to caring, responsiveness, or the other domains. And we felt in the end that actually we should weight them all equally. Now I could spend an hour going through all the arguments. And I mean, safety is crucial, but particularly if you're an elderly person who's in an MFE ward in a hospital, maybe for 2 or 3 weeks, caring is hugely important to that person as well as safety. And if you're waiting for more than 18 weeks for an elective but serious operation, waiting time is hugely important. So in a sense, after we'd gone round it, we decided in the end that actually we should weight them all equally. Having said that, I think when Mike, this is a judge, we are making judgments about hospitals, and I think our inspectors are taking safety hugely important. And I think it's one of the key findings that we've come out in the hospital inspections is that safety is not a given. I used to think that safety was when you got into a hospital, you were in a place of safety. Clearly that is not the case. There are far too many incidents in hospitals where care is not safe. So I think one of our findings is that safety is much more of an issue than we had previously thought. But having considered it long and hard, we felt that we should weight each domain the same. Do you want to add to that, Mike?
Yes, going back to your first question, the good versus compliance question. Because we have the 4-point scale of outstanding, good, requires improvement, and inadequate, we are still very much looking at the compliance end of it as well. It's not one or the other. And where we rate something as inadequate, we will take action on that, normally in the form of a warning notice that they will have to comply with there. And we will go back in and make sure that the provider has improved as a result of that. And when we're looking at safety, we're looking at least a dozen different prompts within safety. We're looking at how well they report incidents and with that, whether they're learning from incidents. We're looking at whether it's clean and whether their infection control is good. We're looking at the equipment. We're looking at the medicines management, the records, the nurse staffing levels, the medical staffing levels, etc., etc. And so we are taking all of those into account. And those are all in the report. And so you will be able to see individual comments on each of those in all of certainly of our recent reports. They will be highlighted. So, I think the very fact that we are coming out saying that safety is the domain which is doing least well, that is putting the focus on it as it stands. And in general, there is a very close correlation between what we are reporting on safety and the overall rating for the trust.
Thank you. Jeremy Hughes from Alzheimer's Society. Firstly, thank you for the report from what I would call new CQC. I think encouragingly, but maybe worryingly, CQC is the only national body we have that brings together health and social care in one integrated operation, and we maybe should learn from that, but make best use of you as well in that. And so I wanted to turn the tables a little bit and just say that there's great engagement and you've built a great relationship with third sector organisations represented here today, involved in the Twitter feed and so on. What would your challenge be for how we should work with you in the year ahead?
David, I think
I thought I brought my 3 colleagues to answer all the difficult questions, David, but anyway.
You can if you want, David.
Yeah. So let me be brief then, and then you can. I think it comes to this point. I think the questions, and Simon touched on this as well, about how do we work together and look not just at institutions but at services and the impact on people. And I think Steve might say something about this before we finish, about the work we're doing on integration. Jeremy, that Andrea fronted the publication of the thematic review on dementia at the beginning of this week, and we think that's a stepping stone in our work around doing thematic work which looks across the piece at how people who are using primary medical services, healthcare services, NHS healthcare services, and adult social care, and many people with complex conditions, older people with complex conditions, will be using all 3 of those sectors, how we can actually look at that. So we'll do that. But I come back to this point about how we use our work, how you use our work as a platform for improvement. Psychoanalysis has this term, fight or flight. And it seems to me that what we want people to do is use our reports as a platform on which you can drive improvement. Learn from the very best. And the report has some fantastic examples of good and outstanding practice. And they're there so those organisations can take pride in what they've done, but they're also there so people can learn from that. They're the go-to places, we think, so people can learn how to do this. So for me, the big issue is how people can put not invented here behind them and actually say, actually we can be better. We can get a marginal improvement, a marginal gain from our work by looking at how the Homerton A&E operates. Let's go and see how that works. What's the best dementia care home in this country? Can people go there and learn what the best care is and take that from us? And it seems to me taking our reports and using them to improve, to be the best that those services can be, is really what I'd like us to do. I think the other thing is we need to be resilient about what we're doing. We need to hold our nerve and carry on doing it. There's lots of people critical of what we're doing, and actually we think we need to carry on and get the benchmark in place. We need to be more effective and more efficient, but we're going to carry on doing what we're doing.
Anyone got a question for Steve, by the way?
We could ask him the one from
well,
Twitter.
Brent,
He doesn't need a question.
Brent on the front, then I'll come back here.
Well, two things really. Firstly, throughout the report, I see the word challenges really, and I think there's lots of opportunities as well. Really, we shouldn't overlook those as well. The question for Steve really, in terms of his work around vulnerable groups, really. If we were to come back in a year's time, Steve, recognising health and social inequalities, it's a tough area, but we have to actually tackle it. What would you like to actually see in a year's time around our work with CQC with vulnerable groups?
Thanks, Brent. I thought I was going to get away with this today. If we're encouraging improvement, we know, as one example, that there are some fantastic services out there, GP surgeries, working with the voluntary sector and across with community care and hospitals for, say, the homeless. Wouldn't it be good to be able to celebrate those practices? Many of those are actually under pressure financially as well, often in poor buildings, and we'll say it as it is. So that might help those particularly surgeries as they're growing and improving. But one of the themes from here is about variation, and the variation in care is unacceptable in all of our sectors. When you think about people who have learning disabilities, the quality of care, the access of care in general medical practice varies. So in every surgery that we visit, we will want to look at how they're looking after people with learning disabilities. But just to pick up David's point earlier on about integration, the future is now, and it's about joined up services. And that's joined up services across health and social care, but increasingly and importantly with the voluntary sector. So one of the key areas we're looking at, which aren't in the vulnerable patient group, but they're vulnerable, are people with dementia. And if you know services which are outstanding, we would like to know those, and we will celebrate those so that other people can share. So this isn't just about shining a spotlight on the small percentage which shouldn't be practicing. This really is about encouraging improvement, and we haven't done that very well in the health service since it was created. Thank you.
There's two questions. Okay.
Thanks. Howard Catton from the Royal College of Nursing. I just wanted to firstly commend you for the very strong, clear message of excellent care where that's being provided by staff across a range of settings. I think it's a hugely important message for staff to hear. Many are quick to rush to suggest that they've lost care and compassion, so for you to say that I think is welcome. I thank you for it. I do just want to pick up on the nursing issue. I think you are right to highlight the issue with nursing homes. The evidence in your report is very strong. 20% short-staffed, the high turnover rates we've heard about. You get better care in a care home than in a nursing home as well. I think that you're doing something important in terms of shifting the focus from nurse staffing in the wake of Mid-Staffordshire just being in the acute sector, but saying this is an issue for social care and community care, and that is a hugely important message to get out there. I think there's an opportunity, if you feel able to say to what do we do for this, how do we fix this? There are opportunities. NICE have done guidance on the acute sector. There seems to me a very powerful case, the RCN have asked for this, to ask NICE to look at care homes and social care much more quickly than they currently plan to. I'm not sure that they plan to at all. Phil Willis is looking at nursing education. There's a fantastic opportunity to say to him, look at placements, look at mentorship, look at the money to support that as well. So there are other avenues as well as HEE that we could use now. Just one very brief comment. your report comes in a week when staff are taking industrial action. We heard the DH, the Secretary of State, at the beginning of the week say there's a choice between pay and jobs. Inadvertently, I think you've held that below the waterline because you're saying there is a pay problem, there is a shortage problem as well. That's a level of sophistication in our thinking that I think that we absolutely require, and I think you're a really important player to help us and to help others to develop that sort of sophistication that's required. Thanks.
Thank you. Do you want?
Yeah, I mean, just to say thanks ever so much. And there are a variety of different things that we can do, and I think it is about using some of the observations that we've been able to make to actually kind of strengthen that and galvanise kind of collective effort to sort it out. So,
David, can I? It's just that this will get focused on hospitals or care and nursing homes, but primary care is in a mess with nursing. We don't have a system in this country where nurses are trained and get enough experience in primary and community care, and therefore they tend to drift into hospitals. And one of the things I'm doing behind the scenes, and will become overtly, we've been working with Howard, looking at the fact that some practices don't have nurses. Now, I do not understand how you can deliver a service in general medical practice without having a nurse employed. The percentages we're looking at are very low, they're small percentages, and we're just analysing the data. But then again, the nurses that are training are of variable quality because they don't have the training when they go into practice. They don't, some cases, get the professional development they need when they're in there. Some are working beyond the scope of practice that they are capable of delivering, and others are working way below what they're capable of delivering by doing things that healthcare assistants and others should do. If we're really serious about reform in the NHS, it has to be about joining things up in the community. It has to be about multi-professional teams engaging pharmacists and nurses more effectively. And what I've been saying, as Howard knows, to government is we need to look at how we train the nurses so that they're encouraged to go into primary care. That will help your issue with nursing homes as well. And at the moment, we're not there.
So, lady at the back, and then come to the front. Yeah.
Pat Drake, Yorkshire Ambulance Service and 111 provider. I can take a lot of lessons here back to the ambulance service, but they're not recognising the system's resilience that the trusts like ours provide. Over 1 million contacts a year with patients. If GPs have problems, ambulance services do in terms of their urgent and emergency care. Patients have problems. Variations in A&E, variations in medical care cause problems. And we kind of feel the oil in the service. Now, I know there's some work starting, but I'd like to hope at some point the urgent and emergency resilience work that goes on that very rarely gets mentioned is going to be integrated into your work and recognised.
Thank you.
David, can I come in on that one? You're absolutely right. And we have now started the work on inspecting ambulance services using our new approach. And we've now inspected 2 Northwest and South Central ambulance services, and our first report is imminent. And so what we've been doing there, this is a pilot, it is working out how we best inspect ambulance services. I don't need to tell you what a large geographical patch you cover, but also looking at how well the call centre operation effectively is working, how good the urgent and emergency response is, any patient transport services separately, and equally the transfer of patients from hospital to hospital, for example. So we are looking at all of those. We believe that our new approach can be applied to ambulances as well as to other services, and we will be reporting very soon.
The lady in the front.
Sue Bott from Disability Rights UK. I'd like to congratulate the leadership of the CQC for taking the voice of the service user and the citizen so seriously. I think that's very welcome. But going forward, I'd like to know how you're going to embed the experts by experience across the inspection regime so that experts by experience are an integral part of the process and not just an add-on?
I think we can all say that they are already a key part. So on all of our hospital inspections, our community health inspections, our mental health inspections and our ambulance inspections, we have experts by experience contributing to those inspections, and I'm sure Andrew and Steve can speak for themselves on their bits.
Yes, I mean, I think there's two things to say, Sue, and thank you very much for your positive feedback as well. The first one is absolutely in social care, we have a total commitment to increasing the numbers of inspections that happen with an expert by experience. We know how important it is that their insight and their ability to get underneath the skin of services, working alongside our inspectors and alongside our specialist advisors, it gives us a much better picture of the service and a much better report. And people like Sarah, who asked the question earlier, are just absolutely vital parts of our team. And the other thing is also making sure that we're using that insight as we help, as we have done up till now, to shape and design what we do. And thank you to you and other colleagues for your work in the co-production group that we've had. But I think that we need to keep that going forward as well, making sure that we're monitoring and reviewing how we're doing things and making sure that we're integrating all of that. And I know that some of you are joining me at our Experts by Experience seminar immediately after this, so that we can continue that work.
Did you want to add, Steve, to that?
No.
I've just got one question from someone on Twitter. I thought it might be Roy Lilly say what a wonderful job we're doing, but it's not actually from me. The question is, what can be done to services that are failing but ignore CQC reports and recommendations? Maybe that's for you, Mike.
I'm not sure there anybody that's ignoring our reports. I really do not think that's the case. It's still early days in terms of follow-up. The biggest single group where we have followed up are the 11 trusts that were put into special measures a year ago following the inspections led by Sir Bruce Keogh. And of those 11, David's already mentioned one, but there were two that have made really fantastic progress, both Basildon and George Eliot, and had already got to being good. And as David indicated, in both cases, they'd sort of taken the initial report on the chin and said, okay, this is a wake-up call, we need to do something about it, and they've made fantastic progress. There were another three that have made very reasonable progress, so we felt able to take them out of special measures, but with ongoing support. There were another group that had made progress. There was no doubt that they'd made progress, but they hadn't yet got to the point where I was confident that their progress was going to be assured and that they would get to good within a reasonable time. And then there was one trust where we really were concerned that progress hadn't been made. And there we are working very closely with Monitor on how to get more support into that trust as quickly as possible to make sure it is turned around. And we've been devoting a lot of time and energy to that to make sure it is improved.
And quickly.
Yes, I mean, I think that what we've got to remember is that we do have a range of powers that we can use. So we have enforcement powers, we can issue warning notices, we can take action which ultimately could cause a service to close. And I think that, as David has emphasised originally, we do want to encourage services to improve. That's the kind of primary focus. But if we're not confident that that's going to happen, or in reviewing and monitoring people's action plans that's not taking place, then we will take the action that our enforcement powers enable us to do.
David, just on this, so the report talks about over 1,400 warning notices that we took last year, but there are now 30 services closed as a result of the action we took last year. That's adult social care, homes and primary medical services. So the bottom line is ultimately that we can close services, and over 30 did.
We're running slightly over time. I'll take two more questions, I think. There's a lady just here near the front.
I'm Sheila Barnes from Health Watch Doncaster. I welcome the report because I think it establishes a good direction of travel for the future influence of improvement of care, whether it's in the NHS or in social care. With the increasing demands and pressures on hospital beds and the growing elderly population, I am concerned about care of the elderly in their own homes in the community. And I was really pleased with your emphasis on the importance of leadership and management, because I think that's extremely important. But I think also there is a need for that leadership to ensure that staff are valued, because if staff are valued, they will do a good job. But what does concern me is that some staff in some areas, they are not paid for travelling time between different cases. And I think that shows a serious undervaluing of staff. And I do hope that the Care Quality Commission can influence that feature and wipe it out, encourage that it shouldn't be used any further. And I do apologise for the musical interlude.
Yes, I quite enjoyed the musical interlude, so thank you very much. You rightly raise two important points, one about leadership and one about valuing staff. And it's quite clear across all three areas where we have established our key lines of inquiry that kind of get under the skin of the question, is the service well led? We are looking at what leaders are doing to support their staff, to train and develop them, and making sure that they are capable and confident of doing the job that we need them to do, and that they've got time to do that in a way which is responsive and caring. So I think that that is the focus of our attention, and we will be looking at issues that you mentioned, the issue about travelling time, and that obviously impacts on people's ability to do the job. And the various tweets that have come through as we've been discussing this morning, really highlighting and emphasising the importance of valuing our workforce in adult social care and across the other sectors as well. But we'll be looking at things like turnover and those sorts of issues to identify where there are risks that actually that leadership culture is not supporting their staff. And if we need to, we will be highlighting that those areas will require improvement if that's what we find.
Tim Gilling from the Centre for Public Scrutiny. Safety is your biggest concern, but coming second to that appears to be responsiveness. That suggests to me that organisations either they're not listening in the first place. If they're listening, they're not hearing, and if they're listening and hearing, they're not understanding and acting. So I wondered what you thought providers and commissioners could do to better demonstrate real-time responsiveness to the voices of people who use services.
If I take the responsiveness domain across the sector that I'm responsible for, it includes clearly things like waiting times and can you get appointments when it's convenient, but it goes much, much wider than that. And within that domain, we always have a focus on looking at complaints and how they are handled and how they are responded to. And it's also where we report specifically on the care given to patients with individual needs, the vulnerable groups. It's where we report on how the hospital manages people with learning disabilities or people with dementia. So it's quite a broad category. And I think as the year has gone on, we've clarified exactly what we want to see in our reports on that, and so that in the future you will always see us commenting on the things I've just mentioned. And I think that will in itself lead trusts to look at that in more detail and to make sure that they are up to speed on those very important areas.
Thanks. I mean, in primary care, responsiveness is usually, we're looking at access to care in different ways is the thing that comes out the most. And we've seen some fantastic surgeries that have really turned round access for patients using lots of different things. And it's not just about using the internet or the phone. The key thing in all of those surgeries is listening to the different groups of patients about what their needs are and finding innovative ways of addressing those. So the first step before you have a problem with access is asking those users and potential users of the service what they need and what would be good. And I was talking to a big group of GP surgeries in the Midlands in the week where they're issuing apps for those who are patients across a very big area, just to try and give real-time feedback about what they need so that they can then address it. Many surgeries are doing far more than you read in some of the national press. Conversely, we're finding some practices which haven't got patient groups are not asking patients what they want from them. And you know, as GPs, and I'm a GP, we serve our patient groups. And if you're not asking them in the first place what they want, what they need, what would be better for them, then actually you're failing. It's very important.
Thank you, Steve. I think we're sort of 15 minutes over our time. I think we probably ought to wrap up now, but I think everyone's going to be here for a while. For anyone else who's got any questions they want to raise with us, just a thank you on behalf of us all for coming today. Your feedback and input into what we're doing is absolutely crucial. So thank you all very much.
Thank you.